Hi, everyone. Thanks for the opportunity to share our process and some of the work that we do with you this afternoon and talk more about Gift of Life and how we match donated organs with recipients. Certainly thank you to our sponsors, CryoLife and CSL Behring. And as we talked today, I understand we have people not only from all over the country, but some international attendees as well. So I did a similar talk back in February for Gift of Life. So if you sat through that, some of this information will be very familiar, and I hope to expand a little more on some of the different parts of the organ allocation process and really hone in on how organs are matched with recipients. So first, a little bit about Gift of Life Donor Program. We're a nonprofit organ procurement organization. You'll hear that shortened to OPO, tissue recovery and IBAC. And Gift of Life was established in 1974. We're the largest organ procurement organization in the United States. And we're the federally designated OPO by CMS for the eastern half of Pennsylvania. You can see there South Jersey and the whole state of Delaware. So within that service area, we work with about 130 acute care hospitals. 15 of those hospitals perform organ transplants, and there's 40 organ-specific programs. And we support a population of around 11 million people within that service area. You can see there the different accreditations we have: the Association of Organ Procurement Organizations, the American Association of Tissue Banks, the IBank Association of America, and then we're a member OPO of UNOS, which I'll talk about a little later in the talk. I'm proud to say that we have the nation's most generous community. And within that service area, we've been fortunate to partner with healthcare teams and through the generosity of donor families. Our service area has seen the highest number of organ donors in the country every year since 2008. In 2020, even through the pandemic, we had the opportunity to coordinate 619 organ donors, resulting in 1,619 organs transplanted. The gift of tissue donation was given by 1,385 individuals for musculoskeletal donation. You can see there just over 1,700 cornea donors, and then about 4,400 night stays at our Gift of Life family house. An overview of Gift of Life and the work that we do, and some of this we'll dive into in much greater detail. We're the 24-hour program, and our role is to take referrals and respond on site to evaluate potential organ donors. We work with families to walk them through the organ and/or tissue donation process, obtain authorization for donation. We'll coordinate the surgical recovery of the organs and tissues. We also, after donation, have a robust family support services department and offer comprehensive bereavement aftercare. We'll work with hospitals, as well as state and national policymakers in the development of policies and procedures. And then we spend a great deal of time providing both professional and public education. So I shared with you Gift of Life service area. There are 56 other organ procurement organizations that provide similar services throughout the country. Those population bases range anywhere from 1.4 million. If you look at somewhere like New York City or out in parts of California, up to 20 million people. Overall, there were 12,588 deceased donors in 2020. So that's a number that has increased a little bit year over year, which we're very proud of and honored to be a part of. In addition, 5,728 living donors. Most common organ donated by living donors is typically a kidney or potentially a partial liver. And then both deceased and living donors resulted in 42,277 organ transplants. Here's a snapshot of organ donation within our area. And you can see the growth in organ donation that we've experienced since 1974. And really the mid 2014, 2015 donation continued to grow. We did dip down a little bit in 2020, really just in terms of identifying potential organ donors and the number of patients in hospitals, and things changed a lot during the pandemic, obviously. Despite all the work we do and despite the generosity of so many donor families and organ donors, the wait list continues to grow. And I recognize that some of you on the call today are either in the beginnings of your transplant journey, and you may be one of these individuals waiting, or you've already received that gift. So right now in the US, there's almost 108,000 people actively waiting for an organ transplant. And 90-some thousand of those individuals are waiting for a kidney. Here within our service area, amongst our 15 transplant hospitals, you can see there's 5,100 individuals waiting, and an overwhelming majority of those are waiting for the gift of a kidney. We also recover tissue as well as eyes. So here's a snapshot at our experience with both musculoskeletal donation as well as cornea donation. And I will spend a little bit of time in a few slides talking about how eye and tissue donation works before we go into organ donor, the organ donor process and allocation. So I shared with you that 130 or so hospitals that we partner with to make donation happen. Every time someone dies or is near death, the hospitals have to pick the phone up and make us aware of the patient. On the left side, those are patient deaths where the patient has died, their heart stopped, or cardiorespiratory death. We evaluate those referred patients as potential tissue donors. So that could be corneas, heart valves, skin, musculoskeletal tissue, saphenous veins, and other blood vessels. The much rarer opportunity for donation are those who may have the opportunity to become organ donors. And when hospitals call us, these are patients that are typically in a critical care unit. They're on a ventilator, and they've suffered some type of insult to their head where they've lost brain and brainstem function. Those are patients that when referred, and I'll talk more about those later, that we evaluate as potential organ donors. And so really the first question we ask when a hospital calls us and says they have a patient to report, we ask whether or not they're on a ventilator, and then we'll know which pathway to put it down as part of our evaluation. An overwhelming majority of the patients referred are evaluated for tissue donation. So tissue donation, while it happens at a much greater frequency than organ donation, it never seems to be as well known unless you yourself or someone close to you received a tissue transplant. One of the most common and better known tissues that are transplanted are your corneas. So those gifts can potentially restore or improve sight to two individuals suffering different corneal disease. Musculoskeletal donation really encompasses a wide range of tissues. This could be anything from tendons or ligaments to the actual musculoskeletal tissue. The opportunity to help there is significant. If you've known someone who's had a knee surgery or an ACL tendon replacement, a lot of times that's deceased donor tissue that's used for that. A lot of folks that have spinal or neck surgery may receive some sort of deceased donor bone to help with that surgery and help with healing. Skin donation has a wide variety of uses. Anything from patients who have been burned. Donated skin can also be used as different types of dressings and coverings for certain types of abdominal surgery. It can also help patients who have undergone mastectomy and breast reconstruction. Donated skin can help with some of that reconstruction. And then even the cells from some organs. So here you'll see a picture of a pancreas. The islet cells can be infused into patients who are really bad diabetics. And that's used in limited numbers at different transplant centers throughout the country. The process for tissue donation is a little more straightforward than organ. The hospitals will make the call to Gift of Life. We'll then triage that referral. We'll collect some clinical information from the care team about the patient. If appropriate, we'll work with the family, we'll obtain authorization, and we'll coordinate the recovery of the gifts. That tissue is then shared with either an eye bank or a tissue bank to really complete the second part of that donor screening process, do all the required infectious disease testing, and then really work to turn those gifts into their final form, and then safely distribute those gifts to hospitals, surgery centers, or dentists for transplantation. The way in which eye and tissue donation is regulated, it's regulated by the Food and Drug Administration. It's very similar to blood donation. So if you've been a blood donor before, if you're at all familiar with the criteria and the screening process to be a blood donor, eye and tissue donation works much in the same way. So I felt it was important to give you a little bit of background on eye and tissue donation before we moved into talking about organ donation. So a question we get all the time is who can be an organ donor? And not always an easy question to answer, because the reality is almost anyone can be an organ donor. It really comes down into the way in which you die as to whether or not that opportunity can actually be realized. So an organ donor is someone who suffered some sort of non-survivable injury. That could be a head injury, a stroke, perhaps they had an event that led to a cardiac arrest where they went a period of time without oxygen going to their brain. And this is a person who's completely dependent on a breathing machine to do the work for them. And while we know there are certainly a lot of deaths that we're made aware of, only 1% to 2% of those deaths in hospitals are potentially eligible to become organ donors, which really makes organ donation a rare and really special opportunity. When we get the call for a potential organ donor, we'll send a Gift of Life coordinator out to the hospital to evaluate the patient. And that individual is going to work with the care team to really work through a comprehensive and thorough evaluation to see if there is eligibility for donation. Our coordinators are all experienced critical care specialists, so many are critical care nurses, paramedics, and have many, many years of healthcare experience in caring for sick patients. Before we talk to the family, we're going to check the donation registry to see if that individual made the decision already to become a donor. That helps us have that conversation with the family if we know that donation decision's already been made. And then we'll manage the entire donation and matching process. And again, with all the complexities involved, this is something that could take 24, 36 hours or even longer. So as you can imagine, it can often be quite difficult to work with a family who's experienced this loss and who's in the midst of losing a loved one. We work really hard with the care team to find the most appropriate time to talk to them. After they're made aware of the fact that their loved one suffered a non-survivable injury or they've been declared brain dead, we'll begin to partner with the care team to work with them and give them that opportunity for donation and talk about what donation could mean to them and their loved one. If they bring donation up, there are some families who may initiate that donation discussion much earlier in the process. And we want to make sure we're there and available to answer questions and talk to them about the opportunity they may or may not have. There are certain instances where a donation opportunity can be compromised by a host of things happening where we may need to speak to the family a little sooner. And before talking to the family, we'll look to see if that donor designation is on their driver's license. Again, we have electronic access to the Department of Motor Vehicles where we can look up their license and see if that decision was made. Or in the case of there not being any sort of donor designation, then it's a conversation with the family where we're asking their permission for their loved one to be a donor. When we sit down with families, here's just a short list of the opportunities that they may have. And oftentimes we're having that conversation. We may not know the entire scope of the donation opportunity, but we find that most families will say yes to every possible organ and tissue. And it's rare for a family to want to limit the scope of how they can help others. So all the solid organs that you would normally think of, your heart, lungs, liver, kidneys, pancreas, intestine, the different types of tissue you can see there. Gift of Life supports a lot of research initiatives and research projects to advance not only transplantation, but science and medicine in general. And families are typically very supportive of any and all research opportunities. And then directed organ donation is a question we get from time to time. If a family knows someone in their personal lives who's waiting for an organ. So our experience with donor families is really overwhelmingly positive, despite the circumstances, despite the time in which we come into their lives to have this conversation and offer this opportunity. Most families are very, very invested in donation. As you can imagine, the opportunity for part of someone to live on in another person is really amazing and special. And we have found donation, most families believe it creates a legacy for their loved one. Very, very grateful when lives are saved, and certainly always wish the best for the recipients who receive those precious gifts. So as transitioning into our evaluation process, we have a responsibility to do a comprehensive and thorough evaluation of the patient, really assessing not only organ function and viability, but there's a safety component as well. And these are the different areas that we really hone into. We do a host of laboratory testing to test for everything from infectious disease testing like hepatitis to your normal laboratory values that if I were going to go have blood drawn, I may have my CBC checked, or I may have my kidney function checked. We'll do that similar type of evaluation in a patient. We do a comprehensive medical social history interview with the family. Again, if you've ever donated blood and you fill out that questionnaire about yourself and different medical and behavior and social type questions, we'll complete that interview with the family. We do a comprehensive and complete review of all available medical records, looking for past medical history. They're looking for anything that could potentially impact organ function or harm a patient. The other piece of that puzzle is a physical assessment, where we do a detailed physical assessment of the donor from head to toe, looking for anything unusual, abnormal, or potential high-risk behavior like intravenous drug abuse. And then additional diagnostics and testing as needed. So, for example, for a potential heart or lung donor, it wouldn't be uncommon to do a CAT scan of the chest or to do a cardiac catheterization to evaluate heart function. A lot of the donor testing we rely on the hospital to do. There is some that's much more specialized and specific to organ donors that we'll use our own lab for. So here's a couple pictures of a lab that is in our building. This lab performs for us all the donor infectious disease testing. They also do the tissue typing. So if you're waiting for a kidney, you're probably familiar with the HLA matching between a donor and a potential recipient. And then here it's important to note that this team also performs the COVID testing on all of our organ donors. So that's the testing and the evaluation piece. We also have to manage the donor. So as soon as brain death is declared, as you'll see, the emphasis shifts from saving the patient's life to really maintaining the family's option to donate and managing the organ donor. When someone's brain dead and can't self-regulate all their organ function, there's a lot of different things. You can see all sorts of different things listed up here that we have to be on the lookout for, and we have to do everything we can to make sure the donor is stable and that the organs continue to function effectively through recovery. So we work under, and you heard me mention it earlier, the Organ Procurement and Transplantation Network, or OPTN for short. So this is the public-private partnership that connects all the professionals involved in donation and transplant. So UNOS, the United Network for Organ Sharing, has held that contract with the government since 1986. And that's a contract with HRSA, that's the Department of Health and Human Services and Resource Administration. This is the organization that we're all members of. Everybody involved in donation and transplants a member of the OPTN. And that's the team and organization that establishes policies and really oversees the work that we do. And most importantly, as you'll see, helps us match donated organs with transplant candidates. And they use a system called DonorNet or UNet, and you'll hear me use those terms in some upcoming slides. So the goal of the OPTN, and these are all great goals, and we certainly share in them, to make as many organs available for transplant as possible, to make sure there's optimal processes in place in every part of that donation and transplant journey. Equity and access to transplants, and really that centers around the opportunity to receive a transplant fairly when compared to others, no matter where you are in the country, no matter what ethnicity you are, no matter how close or how far you are to a transplant center, whether you live in the city or the country. So not only increasing the number of transplants and access, but also outcomes for patients. We want those gifts to last as long as possible in each patient. We want to transplant the most appropriate patient as possible. And then certainly there's a part as it pertains to promoting living donation, and then making sure recipients are safe. All the policies are written and developed in a way that really takes these two principles into consideration. The first being justice. And when you're creating allocation policy and when you're determining how to allocate a scarce resource, such as an organ, you want to be fair to everyone involved. So it's fairness in distribution. You also have to balance that with medical utility. How can we make the most medical good overall of such a scarce resource? And that's where some of the policies will take logistics and distance into consideration to make sure the organ is going to the sickest person who's been waiting the longest, but also within the most reasonable distance or time between the donor hospital and the transplant center. So the system, we use the UNOS computer system to help us make that decision in terms of what we call a match run or a list. And as an OPO, we'll input the deceased donor information into the computer system. And when candidates are listed for transplant, the transplant center will put their information in the system. And then we'll talk about what the lists look like and how that happens in a moment. We use to allocate organs a system called DonorNet. This allows us to electronically notify transplant centers on the match run of an available organ. And they can then go in and look at and see the patients for whom it's being offered for. They can access all of the donor information. They can access images. They can watch or view different studies that were performed as part of that evaluation process to really get an understanding as to whether or not that particular organ might be appropriate for their patient or patients. So what's in there? Our goal is to share as much information about the donor as possible to help a transplant team make the best, most informed decision. So basic information about the donor, such as the cause of death, their prior medical or social history, their age, their gender, their blood type. And some of this is used proactively to match candidates. So if you're waiting for a heart, your transplant team may set upper and lower age limits for donors that they want to hear about that might be appropriate for you. And then certainly blood type is a large part of that donor matching process. Here are some other items that are other data points that could influence whether or not a particular recipient is appropriate for an organ from a particular donor. That's why every match run that we run, our list of potential recipients looks different because so much of it is based on information about the donor. So the donor's height or weight, their infectious disease testing results. Some patients may be okay receiving an organ from a donor that has hepatitis C, while others may not be. There's certain laboratory tests that are organ specific. So if the kidney function tests are above a certain level, a transplant team may not consider a kidney offer for that patient. A question we get a lot is how long can organs be outside the body? And if you think back to the justice and medical utility slide, this time factors in on a lot of those allocation decisions and organ distribution policies. For example, when we look at a heart typically has to be transplanted between the donor and the recipient within 6 to 8 hours. So it would be unusual for us to share a heart with a patient as far away as California. That heart will likely stay much closer to the donor hospital to allow the recovery of the heart, transport to the transplant center. Whereas we frequently send kidneys that can be outside of the body in a box on ice for 24 to 36 hours. It's not unusual to send a kidney as far away as California. And then there you can see the other organs. So we'll get into how the organ matching process works. We'll talk quickly really about each organ. You'll see in most cases, organs are matched with the sickest patient waiting the longest is really the goal in this process. Hearts, it's based on medical urgency, distance from the donor hospital, and then certainly special consideration is given to children. And that medical urgency, there are different heart statuses, and based upon how sick you are, how long you've been waiting, whether you're in the hospital, out of the hospital, whether you require some sort of assist device or certain medication will dictate your medical urgency for a heart or dictate your status. Lungs, it gets a little more complicated. They look at the overall survival benefit, how sick the patient is. There's something with lungs called lung allocation score, which takes into consideration a lot of variables in the patient to give them a score. Certainly waiting time, distance from the donor hospital, and then again, special consideration is given to kids. For livers, medical urgency again plays into that. Just like with lungs, there's something called the MELD score that takes certain laboratory values and other tests into consideration to determine a potential recipient's MELD score. And then that MELD score will dictate where they may appear on a match run for a deceased donor liver. And you'll see their distance from donor hospital plays into all of the organ systems. And in general, organs are going to be offered first to patients within 250 nautical miles, or as we say, the way the crow flies, from the donor hospital. So that's really the sharing radius of the circle, where all the deceased donors within that circle will be shared with transplant centers within that circle. There are certain instances where a patient who's really sick, or in the event of a kidney who's a really good match, may be much higher on that list and are outside that 250-mile circle. And then lastly, kidneys and pancreas. It's based predominantly on waiting time and how long you've been on dialysis. Tissue typing, or what kind of match there is between the donor and recipient. Patients who were prior living kidney donors are given special consideration should they have previously donated a kidney and then find they themselves are in kidney failure. They have an opportunity to be placed much higher on the list. And then again, you can see here distance from donor hospital, survival benefit, and then pediatric status all come into play. I can't show you a map for each and every organ. However, this is what our kidney allocation map would look like. So if we have a deceased organ donor here in Philadelphia, here's a look at the distance of which we would be sharing those kidneys. There's up to 63 kidney transplant centers within this circle. It's a population of almost 70 million people, and there's about 23,000 patients waiting for a kidney within this circle. So, when we look at this, if we have an organ donor here in Philadelphia, the most appropriate patient may be up in Massachusetts, but then upstate New York, they may have an organ donor, and the most appropriate patient for that kidney is here in Philadelphia. So in this instance for kidneys, the kidneys are moving all about this circle. And this circle is going to shift in any direction with the donor hospital being the center point of that. Transportation is a big part of what we do. We have to facilitate transportation of the surgeons who are going to travel to the donor hospital to recover the organs. We may do that by ground, either in an ambulance or a vehicle that you see here, a helicopter, or an airplane. And then we also have the responsibility of, once the organs are recovered, of getting them to the transplant center. And if it's a team that's come out to recover a heart, the heart would travel back with them. Same for lungs, but liver and kidneys, there may be instances where it's a different team doing the surgical recovery than who's going to receive the liver or kidneys. And we'll use similar methods of transportation to get them to the transplant center. Here are just some of a quick overview of the considerations and the different things we have to factor in during either the organ and or tissue donation process. We work closely with coroners or medical examiners. If it's a traumatic or sudden or unexpected death, we have to work collaboratively with the coroner or medical examiner to make sure their needs are met, given their responsibility to determine the cause of death. And we work very closely with them to make sure donation can become a reality, but then also that they're able to do what they need to do in regards to the investigation and giving family that valuable information. Working with the operating room team at the donor hospital, we covered the procurement and the preservation of the organs. Tissue recoveries will happen really in the similar manner in an operating room. And then again, working with the coroner or a pathologist if there's to be an autopsy, and then making sure we do everything we can to get the decedent released to their funeral home in a timely manner. So there's a lot of things to think about, and some of the questions you might have as a transplant patient. Maybe you get the call, maybe you've gotten many calls that an organ might be available, and then you later learn something happened in the operating room or after the organ recovery, and the transplant team decided that organ wasn't appropriate for you as an individual. We have to look at tissue typing, and this is most common with kidneys. What's the tissue match, or the HLA type between the donor and the potential recipient. And if you're a kidney patient that's been transplanted before, you may be highly sensitized, so you may be really hard to match. You might have what's called unacceptable antigens. Maybe you have a cross match done that's incompatible. The size, between donor and recipient have to be weighed and determined. Recipient appropriateness. Both our organ donors and then certainly candidates waiting may have different levels of vessel disease that would make putting in an organ from a specific donor challenging or even not possible. When the organ's recovered, we call that the organ, we're getting a firsthand look at the organ. We'll look at the anatomy of the organ. There are times we'll do a biopsy to help us with that evaluation. Some organs we put on a pump to determine how well they may work in a recipient and to really help that evaluation and make information available to the transplant team. All that data really will factor into that decision a transplant team may make about final acceptance of an organ. Here are some of the logistical things that we have to plan for. Given the limited time we have to transplant an organ once it's recovered, and all the moving parts that are happening both on the donation side and at the transplant center, we really work hard to plan for every possible scenario. So for every organ that's donated, we're not only identifying an intended recipient, but we're also identifying backup patients. So if you have been waiting for some time, my guess would be that many of you have received that backup call of, you're not quite primary, you're not quite the intended patient, but we're identifying more patients in the event that something comes up that the intended patient isn't able to be transplanted. That could be due to unexpected findings in the patient, in the donor, or the recipient. Those could be logistical challenges, anything from transportation issues to weather to timing. The other thing we're aware of that we know happens from time to time, candidates could be listed at more than one center. And that really becomes a personal decision, between you, your family, and the transplant centers. It can get a little confusing for us when we see the same kidney patient on a list at a center in Philadelphia and at the center in Ohio, and how to navigate that. Other common questions we get, this is probably one of the oldest myths out there, is if you put the organ donor designation on your driver's license, will the care team still save you? Hospitals can't access the Department of Motor Vehicles registries to see whether or not you have the organ donor designation on your license. And I can assure you they're not looking through your wallet to see whether or not you're a donor. Their emphasis is going to be on saving your life and exhausting every attempt to do so. For us, we encourage everyone, if you want to be an organ donor, to make that known by putting it on your driver's license and making that decision known to your family. Some other questions that we get from time to time is the potential impact on funeral plans. There's really no part of the donation process that will impact the family's ability to have an open casket, traditional viewing, should they choose to do so. Many organ and tissue donors also have an autopsy to get additional information as it relates to the cause of death. Does a person have to die in the hospital to be a donor? To be an organ donor, yes. And again, remember, that's a potential organ donor is in a critical care unit. They're on a ventilator. They still have a heartbeat. Their organ functions preserved, and their body is being ventilated in an ICU. A potential tissue donor could be a death outside of the hospital who's then transported to a hospital or a medical examiner's office, and then we can evaluate those patients as potential tissue donors. And then if someone uses drugs, can they be a donor? And the answer to that is yes, and that's drug use is taken into consideration as part of the evaluation process. And then questions we'll hear from on the recipient side, and I covered some of this, when you're called several times prior to actually receiving an organ. And if you think about all those variables I mentioned earlier, there could be a lot of, what we'll call dry runs or false starts. The testing process required to be listed for a transplant. that piece I'm not as familiar with, but I know there's a robust evaluation process that transplant centers will go through to make sure a potential recipient is appropriate for transplant, is safe for transplant, and all benefit from the gift. The last one I recognize can be a challenge for some is why are people transplanted faster than others? Certainly so much of that depends on medical urgency and how sick you are. And then, yes, transplant recipients can be organ donors. So I figured I would cover some of the common questions, and I'll turn it over to Talia now to see what other questions we have.